various anatomical variations in MCA. So this is a normal thing which we study, the MCA bifurcation into equal trunks. Sometimes you can have some particular trunk being dominant. So either the superior trunk, the inferior trunk can be dominant, or superior trunk can be dominant. And then you can have a trifurcation. You can have a trifurcation MCA aneurysms. And this is a quadrifurcation. This is a quadrifurcation. The case which I would show is we will have a trifurcating aneurysm or a MCA trifurcation. And then these are the various branches from the MCA. So the MCA, usually when it is when you have a bifurcating pattern, so we divide into the anterior and the posterior. Okay, so this is the bifurcating pattern. So the various branches arises from the anterior segment and the posterior segment. And if it is a trifurcating MCA, you might the branches will arise from anterior, middle, and posterior. So branches arising from the anterior segment of the MCA in the case of MCA bifurcations, you get an orbitofrontal branch. This is the opercular frontal branch, and this is the singular. These are the central arteries. Okay, the orbitofrontal branch, the opercular frontal branch, and these are the central arteries which arise from the anterior segment. The parietal posterior, the anterior and the posterior parietal, they also take sometimes they also take origin from the anterior segment. And then this is the gyrus angularis. And then the temporal branches, they take origin from the posterior part. So these take origin from the posterior part, and all these takes origin from the anterior segments. Whereas in case of a trifurcating one, the orbitofrontal and the operculofrontal takes origin from the anterior segment. The middle segment gives origin to the parietal and the central arteries and the gyrus angularis. The posterior trunk gives division to the temporal branches. So this is how roughly the bifurcation and the trifurcation of the MCAs, how they give branches to supply the lateral convexity of the cerebral hemisphere. So the other views, the lateral view and the superior view, showing the various segments and various branches of the MCAs. So now into the steps of dissection. The first and foremost thing in approaching the MCA for any aneurysm, be it, is the Sylvian dissections. For the anterior circulating aneurysm, the first and foremost step is the Sylvian dissection. So preoperatively, you should try to assess what is the type of the Sylvian fissure. There are various types of Sylvian fissure, which I will show you in the subsequent slides. So you need to assess the anatomy of the Sylvian fissure preoperatively. So first step is the Sylvian split. So you need to make an incision in the cortical arachnoid. So this is the cortical arachnoid incisions. And then remember, always temporal mobilization of the Sylvian veins has to be done. Temporal mobilization of the Sylvian veins has to be done. So this is the cortical, make an incision in the cortical arachnoid and then make a temporal mobilization of the vasculatures. So once you open the arachnoid, the cortical arachnoid, once it is dissected, so this is how you see that is the MCA bifurcation. So now you can clearly see the MCA bifurcations. So the first two steps is the making the cortical incision and then temporalizing the vasculatures, and then follow the cortical MCA branch. Okay, follow a cortical MCA branch to the opercular branch. So this is the cortical MCA. Okay, so this is the cortical MCA. From then you will get the opercular MCA. So follow the cortical MCA to the opercular MCA. And then you will follow, once you enter the operculum, follow the opercular MCA to reach the insular MCA. So M4 to M3 and from M3 to M2. So then you will reach the insular MCA. So now you should understand the various types of Sylvian fissure. So this is an atrophic fissure where the Sylvian dissection will be really very easy. So this is an atrophic Sylvian fissure. You can have an opposed Sylvian fissure where the frontal lobe and the temporal lobe, they touch each other. Or you can have either a frontal herniating Sylvian fissure or a temporal herniating Sylvian fissure. So this understanding of the anatomy of the Sylvian fissure is very, very important. So when you plan your surgical approach. So always have a preoperative understanding of the anatomy in order to avoid intraoperative surprises. Okay. So these are the various types of Sylvian fissure. The first is one is the atrophic Sylvian fissure, the opposing Sylvian fissure, the frontal herniating Sylvian fissure, the temporal herniating Sylvian fissures. See, all these pictures are taken for the educative purpose. I have taken it from the Barrows. We don't get these pictures in humans or other books. So these are from the Barrows 7 aneurysms. So all these aneurysmal illustrations, you can refer Barrows, that is, sorry, Lawton series, Lawton's 7 aneurysm series. So read aneurysms from Lawton 7 aneurysms textbook. So it will be a bit of higher standard, but still that anatomy and orientation is very, very important to understand things. So then this is how the vessels will be attached to the frontal and the temporal lobe. So always remember, they can have adhesions. The vessels we need to dissect along these adhesions. So the vessels can have adhesions to the same lobe that it supplies. Okay, the artery may adhere to the same lobe as it supplies, or it can adhere to the opposite lobe it supplies. So you can see here the vessel is supplying the frontal lobe, it is adherent to the frontal lobe. Whereas you see here this vessel is supplying the frontal lobe, but it is adherent to the inferior, that is the temporal lobe. So that thing also you need to understand. So you have to dissect along these adhesions to mobilize or free the vasculature. So then again, here in MCA aneurysms, you have the terminology of tilt. Whereas in anterior communicating artery aneurysm, we will have something called as projections. So there we had a superior, inferior, and anterior projections. Here we have superior, inferior, anterior, posterior tilt. Okay, so MCA aneurysms, you describe as tilt, whereas anterior communicating artery aneurysm, you describe as projections. So you need to assess the MCA aneurysm through various views. So you need to have the coronal view to assess whether it is superior and inferior. And you need to have the axial view to assess whether it is anterior or posterior. So both the views has to be studied to orient to the various tilts. So you can have an, so this is the lateral tilt. Okay, this is the lateral tilt. This is the inferior tilt where the dome of the aneurysm is adherent to the temporal lobe with an upward arch of M1 MCA. Okay, in inferior tilt, the dome of the aneurysm is adherent to the temporal lobe with an upward arch of M1 MCA. In superior tilt, the dome of the aneurysm is adherent to the frontal lobe with an downward arch of M1 MCA. So always remember, it is the convexity of the vessels, or any convexity is always taken into consideration. If you take in spine, if you take in scoliosis, it is the convexity which determines the classification of the scoliosis. So again, here, the convexity, the convex surface, whether it is superior or inferior, that needs to be taken into account. So it is the convexity which is most important, not the concavity. Okay, so this is a superior tilt where the dome of the aneurysm is attached to the frontal lobe with a downward M1 MCA. Then you need to assess the axial view to see whether it is anterior or posterior. So this is a posterior tilt where the dome of the aneurysm is adherent to the temporal lobe with an anterior arch. Okay, with an anterior arch. Whereas this is an anterior tilt where the dome of the aneurysm is attached to the frontal lobe with an posterior arch. Then posterior arch. So these are the various types of MCA aneurysms. You can have a lateral tilt. You can have a superior and inferior tilt and lateral tilt based on the coronal view. You can have a posterior tilt or an anterior tilt based on the axial view. So you should orient to the three. So step 1, it is follow the superior trunk. Follow the superior trunk. So these things should be started as I said earlier, follow the cortical MCA to the opercular MCA, from the opercular MCA to the insular MCA. So here, first follow the outer surface of the superior trunk and prepare the M1 segment for the proximal control, and then follow the inferior surface of the superior trunk, and then follow the the inner surface of the inferior trunk, and then dissect the distal neck, and that which will be the blind spot. So this is the distal to proximal MCA aneurysmal approach. So you can have a proximal to distal MCA approach. That is, first dissect. This is the free areas. That is the safe margin for dissection. The medial border of the ICA, the inferior border of the A1 ACA, where there will be no branches or no lenticular striate arteries. So these are completely the safe areas for dissection. So dissect along the supraclinoid ICA, and then dissect the A1 ACA inferior border, and then identify the anterior choroidal artery laterally, and prepare the proximal M1 for getting the proximal control, and then shift to the distal sylvian fissure, follow the outer surface of the sylvian fissure, and then follow the outer surface of the superior trunk, follow the inferior surface of the superior trunk, follow the inner surface of the inferior trunk, and then dissect the distal neck, which will be the blind spot. So then the aneurysm will be freed and the neck will be accessible for clipping. So once all these dissections are done, the neck will be easy to put the clips. So approximately 15% of all sacral aneurysm arise from the MCA. Typically, they originate at the level of the first major bifurcation or trifurcation of the artery and point laterally in the direction of the long axis of the pre-bifurcation segment of the MCA. The more proximal the bifurcation, the greater the number of lenticular striate branches arising distal to the bifurcation that may be stretched around the neck of the MCA aneurysm. When unruptured, these aneurysms are typically clinically silent.